Welcome everybody. Welcome everybody. So glad to be here with you. We're gonna do a brief introduction to ICD FlexFit. So uh, ICD FlexFit, sorry, scleral lenses were developed by John Montfort, Patrick Caroline, Robert Heaviside, Dave Barreto, and Randy Kojima. So big names doing a great scleral lens, right? So ICD Flex is basically designed for any type of eye shape. So you can have the PMDs, the severe keratoconus, oblate corneas, prolate, like irregular corneas, any type of cornea that you see, you can fit it with ICD Flex Fit. So one of the things that we always try to achieve with a scleral lens is bolting the apex of that cornea, right? We need to achieve bolting that apex, the limbus, and just try to have that smooth landing with that scleral lens, just to avoid a lot of complications that can be done with a tight lens. So with ICD, we have two standard diameters that can accommodate small and large fissures. Um, Prolate, like severe prolate corneas or oblate corneas, um, high and low sag eyes, and fitting inside and outside pinguiculus. We have two diameters, like I was mentioning, the 14.8 and the 16.3, and we're going to talk a little bit about what is the the design has to offer for us on each diameter. So how to choose the correct diameter? So there's this standard rule that you see here, which is the HBAD or the BID plus 3.5 millimeters. Someone says, like, there are other professionals that says that you can go 3.5 or 4.5. And it's just gonna depend on what type of eye you have in front of you. So if you have this big prolate cornea, maybe best to go 4.5 and just choose a larger sag lens just to bolt that apex of the cornea. But you can just go with a 3.5, which is the standard, and choose the closest diameter. So if you see this image here, you can see that we have a 10.5, and with a 3.5, that should be like a 14. Then we should go to a 14.8, right? But with a 13, which is a huge cornea, uh, uh, I've seen like little corneas being that large, but mainly 12.2, 12.5. With a 3.5, I think it may be a little bit tight. So I will prefer in this type of cases a 4.5, but instead, like if we go with a 3.5, a 16.3 will be the one to choose, right? But this is just what the trial set just gives us, right? We will talk a little bit about what options do we have for diameter choosing. So choosing the 16.3, like it says here, is less sensitive to visible iris diameter considerations, meaning that you will bolt over the limbus, you won't have limbal bearing. Most of the times, choosing a large diameter, we try to achieve bolting that limbus without any bearing on the limbus area, right? But like I was mentioning before, the options that we have is that we can flex the diameter. And by flexing the diameter, we maintain the actual sag that we see on the fit. So for instance, if you achieve like 300 microns when you are fitting the lens and you are okay with that 300 microns, which can vary from practitioner to practitioner, because for me, my go-to maybe would be like a 350, just because I would like to the lens to settle between 100 and 150 microns, and that's why I would choose a 350. But let's say you have a 300 microns and you're okay with that, but you see that you need to go larger with the diameter. You can go larger to even to a 15.5 with a 14.8 and maintain those 300 microns. So it won't change just because the algorithm of the design just lets you go larger or smaller and maintain the central side. So, and this happens as well with with the 16.3. You can go smaller to the 15.5 where you left off with the 14.8, and you can go larger to a 17 and just maintain the same apical clearance. So, like I was mentioning, it doesn't matter how large you go, you can just maintain the central sag the same, which is different than the total sag of the lens, right? So the algorithm will allow you to go larger or smaller, maintaining it. So this is something great, really. So with this 16.3, we have a dual depth periphery because, as we know, as far as we go from the limbus, we get more toricity on the sclera. So we need to compensate for that toricity, and just the reason is to align it better to the shape of that sclera. As where with the 14.8, this is a symmetric landing. And obviously we know that we can have still a little bit of toricity near to the limbus, but it's more uncommon to have it. But if you choose to do a 14.8 with a little bit of toricity, you can do. There's other designs that have a small diameter, like a 15.0, and have a little bit of toricity as well, just like 50 microns of toricity. You can just do it. And the way that you will do it is just basically by assessing how the lens is fitting on the eye, right? So if you have blanching 3 and 9, maybe so that you need to do a little bit of toricity as well. So, but it's available and you can do it with the 14.8 as well. So, uh, like mentioning before, there's the ability to do dual depth, or you can just choose as well with the 16.3 asymmetric lens. It's up to you, but the standard is the 14.8 being symmetric and the 16.3 being a dual depth. And when we say the dual depth, the amount of toricity that we have with the 16.3 is 125 microns. So this will be displayed on the LLC steep field as a +5 because each step has 25 microns. The ICD Flex Fit is also available on quad-specific landing, but this is only available on the 16.3. So if you were to choose quad-specific, it's only available on the 16.3. And just just so you know, this begins at the limbus, the quad specific. So the changes will go from the limbus to the outer part of the lens. So one of the questions that we get is if we have multifocality on ICD Flex, and yes, we do. We have distance zone and near zone. So you can ask for CD or CN as you require. And the good thing is that you can just manage the diameter of the distance zone as well. So you can just go larger or just go smaller, depending on the pupil size of your patient. This here's an example or how the distance center options are basically done for you. Sorry. You can see going a little bit smaller. Where's the intermediate zone, which is this is distance. and how this affects the near zone that you have. So again, you have as well the near center, and you can just change the diameter of the near center zone as well. And again, here's just a graph just showing you how this affects the other zones. But one of the things that we really like with ICD Flex Fit multifocal is that we can displace the optic, because we know that most of the fits will decenter either inferiorly or go inferior and temporal, just because of the shape of the eye, and the cone can displace that lens a little bit. So in order to achieve good BA with our patients, what we need to do is have, with multifocal fittings, we need to have good distance visual acuity, at least 20/25, good centration, and the motivation of the patient, right? But if we do not have centration, so we can just displace the optic zone for the multifocal part of the lens. So as you see here, we have the symmetric multifocal, a mild displacement, and a high displacement of the optical zone. So this may be achieved just by you saying like, we need to displace, the lens is sitting below inferior and temporal, and we need to recenter the optical zone for multifocal. So this can be done, okay? So as mentioned before, we can really go with an oblate cornea, which will be an extremely low sag eye, and a prolate cornea, which will be a high sag eye, right? So in order to do this, we have our fitting set, our diagnostic set, and we have a going back, a large amount of SAG values that you can see here, from 3,800 to a 5,400 SAG. And just you can see the base curve with a flat base curve of 845 to a steep base curve of 625. So, and the powers will change accordingly. With the flattest cornea, we have a positive power. Then with a steep lens, sorry, we will have a minus power of minus 14. With the 14.8, this is really great because we have a 3,400 SAG value to a 42. So we have a wide range of lenses that we can fit on those extremely tough eyes. So it doesn't matter if we have a post LASIK, we can order that lens, and we can just make kind of like a reverse geometry lens. And we'll discuss a little bit about that later on. As well, if we have that uh, bulging eye, like a prolate, big prolate cornea, keratoglobus or so, we can achieve that fit with a 5,400 SAC value here, and just do the fit, and it will work out pretty much. So again, here's just a kind of like a guide on what lens to choose according to the diameter that you're fitting. And as you can see here, and transplant will go from 48 to 54. I mean, this will be as well for a keratoconus or a keratoglobus as well. And normal eye of 4,000, 3,800. So this is just like I was mentioning you, a guide on what lens diameter to choose and what SAC value to choose. Okay. So I think you are pretty much well experienced scleral lens fitters. And this is just a reminder on how to, or what can we do to place that scleral lens on eye. Just using a DMB, tripod, or two fingers. Just remember that with either, I mean, The tripod, I think it's more stable than the two fingers just because of filling it out with saline solution. And this could just be a little bit of a mess if you don't put it on quite well. Then, like it's just a brief reminder, just fill the bowl, put fluorescein, and just assess. And, if bubbles are present, remove and reapply. This is just the basic stuff that we usually do with our patients. And as mentioned before, as you being an experienced scleral lens feeder, I you know already much about this. Then, obviously, if we see something like this, I mean, the the right thing to do is just take it out, put another sag, because like you can see here on the sag values, you can just go 200 microns. So if I were to see this, I wouldn't go just 200 microns. I probably would go to 400 microns more, just because I just want to bolt. I know I have touch, and I know it's going to be an asymmetric fluid reservoir, just because inferiorly we have that touch and superiorly, so it's just going to be asymmetric. And we don't have to stress out when we have asymmetric fluid reservoir, just because there's basically, like, the labs and consultants have like a rule of thumb that if the separation between the apical clearance and the mid periphery is not as large as more than 500 microns, then it's just basically a good fit. And that's why we don't have to stress and just make many changes to achieve a more symmetric fluid reservoir. So I will go, in this particular case, I will go to 400 microns in difference, just because I know I have touch and I just want to leave a good lens settlement after use. So what's the schematic of the ICD Flex Fit? Is just being four peripheral curves and the optic zone. So you have the center zone here, the mid periphery, the limbus, and the scleral landing zone. So you can see it here, and you can see all these lines, and you can see the green line just going in the middle here. And we're going to talk a little bit about what changes can be done and what affects. Uh, what zones does it affect if we change zones? So, uh, does it alter the sag? Yes, it will. The central sag will be affected if we change mid-periphery, limbal, or scleral landing zone. So the way to go is we have our central zone, and this central zone is just going to be managed by a base curve, and you can just change that base curve, and by doing so, it will just raise up or decrease the central clearance, and it won't affect the other zones. So this will be done just on the optic zone, or the central clearance zone. And I mean, it's one diopter of change in the base curve will change about 50 microns of central clearance. So for that reason, because if we steepen that base curve by one diopter, we have to do the SAM-FAB rule, which is steep at minus, flat at plus. So if we were to increase one diopter of change, so we're steepening, so we need to change that diopter into the power as well. So that conversion has to be done. That's why changing central clearance zone is not the most common thing to do. If you want to change central clearance zone, then you go to the peripheral corneal clearance zone. And this will affect the central zone, as you can see here, but it won't affect the limbus or the scleral landing zone. So you will raise central optical zone. And by doing so, you won't be changing the power, you won't be changing the base curve, but you will change the central zone so you can achieve what you are looking for, either to increase or decrease the central zone. And if I'm doing a reverse geometry, probably so that I would do an increment in the peripheral zone and just flatten the base curve and just try to lower down the fluid just to achieve a good kind of symmetric fluid reservoir for an oblique cornea. So, like I was telling you before, this only affect the central zone, and you can just go by steps, again, 25 micron steps. And one of the things that Randy, as a designer, suggests here is try to achieve not that much of like going over 8 steps, because if you go over 8 steps, you are changing to 200 microns, sorry, at the center. And if you are changing 200 microns at the center, it's probably best to choose another lens. The reason is try not to make as many changes because sometimes making that many changes on a lens design may alter the final result. So if you're changing over 8 steps on the zone 2, I would strongly suggest as well to change the lens. Just take it out, put it in. This will only, I mean, depending on the patient, obviously, but it will almost always be around a minute or so. So yeah, and even if you're flattening if you're flattening -8 steps, again, just drop down and go to the previous lens, right? This will basically be a more consistent fit than just going and altering the fit of the lens with over +8 steps or -8 steps. So then we have the limbal clearance zone, as you can see here. And one of the things that we want to achieve with the limbal is some practitioners prefer to go 50 to 100 microns. Uh, Other practitioners prefer to go 125. The reason is because the lens will settle, so the lens will drop down, and it just doesn't drop down only on the central zone. It will drop down all the way. So if you have a little bit more of a cushion, then it will drop down and just leave a good clearance on the limbal zone. So by changing the limbal clearance zone, look here, you can see that it affects zone 2 and central zone, but it doesn't affect the landing zone. So it will always affect to the upper side of the lens instead of the lower part. So we want to avoid limbal bearing or having that huge amount of limbal clearance, right? Because if we have limbal bearings, we will have corneal edema. So it's going to be bad visual acuity. But if we have like a large limbal clearance, then we will have conjunctival problems, mainly that we will see on the inferior part, because sometimes by the lens decentering a little bit, it will create that type of pris on the fluid reservoir, and then you will see that that conch is gonna get in and just settle in between the lens and the cornea. So this, and we can just manage by changing the limbal clearance zone as well. And then we have the scleral landing zone. And here you can see that it will change the landing. And this as well is gonna change a little bit on on all the zones. And here, what we want to do is if we want to go flat, we will go with a minus sign. Like if we want to flat, we're gonna raise that area. So it's gonna be a minus sign. And if we're gonna steep that area, just the edge, we're gonna go with a plus sign. And again, it's 25 micron steps. And the reason of why is it going to be a minus? If we flat, we're gonna let the lens sink in. If we're gonna steep, it's gonna raise up. So that is why it's negative or plus signs in this landing zone. So there's this guide sent by the lab and the designers, and where it says how to go according to what you are seeing actually on the slit lamp. And if we have a mildly tight lens, just go with a scleral lens landing zone of -1. Um, I mean, as it says here, it's just one accurate area of bezel restriction. If we go to a moderately tight lens, order an SLC, sorry, -2. And here's the thing, because it says opposite side of bezel restriction. Um, what we have seen that works a little bit better is if we see, let's say, blanching 3 and 9, we may have a scleral toricity with the rule. So as I mentioned before, the 16.3 is a dual depth lens, and those markers that you saw on the picture, and if you want, I can go back. Those markers were actually pointing out where the flat meridian is. Uh, and as I mentioned as well before, the toricity of this lens is basically done on the steep meridian. So you will see the flat meridian marker. And if we see those 3 and 9 and the flat meridians being at 3 and 9, we may likely do better with increasing toricity in this particular case. As well, if the lens rotated and the markers were uh, at 6 and 12, and we saw a little bit of blanching, then we have a scleral toricity against the rule, and as well, we want to go. But if we see some blanching at 6 and 12 and the markers are at 3 and 9, then decreasing the toricity will make it better. But another suggestion is just going with an SLC of -2. And if we see over 180 degrees of bezel restriction, then just go to a -3. This is the recommendation, but you can go a little bit higher. Just remember that by doing -1, -2, -3, you are losing 25 microns at the center, -50 or -75. And you can compensate for those losses with the other zones. So for instance, and I will go back a little bit here. So for instance, if I'm changing the the scleral landing zone, right? If I'm changing the scleral landing zone of -25, the best my best suggestion to you would be go to the peripheral corneal zone and just change and steepen that 25 microns that you're losing. And the thing is just to try to maintain the same central apical clearance and not altering. But let's say, and let's make an example. Let's say you have over 500 microns of central clearance. Well, basically, if we have 500 and you just want to go and make changes, then you would just go with lowering the central sag by doing either base curve, and you can just make it like kind of like uh, basically a joint change between the central clearance zone, doing changes with the base curve and the peripheral zone. Just try, because that way you won't be changing that much the design. Remember that you want to maintain a back posterior surface of that lens as smooth as you want and not have that junctions between those zones, high or low, that it will create kind of like a block here, like here, 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 here. You just want to go as smooth as you can on the back posterior surface. So again, you can just manage those changes and just compensate for losses or gains that you are doing with each zone. So uh, you have the ability to make the lens as you wish, but my suggestion again is try not to make that many changes. And if you are over 500 microns, just go back down to another lens and then just reassess the fit. So with that being said, let's go to the key points and the advantages of the ICD Flex. Again, just remembering that we have 4 zones: central clearance zone, peripheral corneal zone, limbal zone, and scleral landing zone. And each step that you take is going to be 25 microns. So just as far as you can go is plus 15 and minus 15. Again, the suggestion by Randy is go not above plus 8. If you go above plus 8, then change the lens. And as you can see here, it's gonna be 3400, 3600, 3800, 4000, and 42. So it's just 200 micron steps on SAG. And like I was mentioning before, if you are 500 microns above the 4400, just drop down to a 42 and assess the lens for a better fit. Again, it's a lens that can fit mostly all shape of the eyes, from a PMD, keratoglobus, post-LASIK, so just limbus to limbus astigmatism, so an irregular cornea, so you can fit all of them with just this one scleral lens. So again, 2 diameters, one approach, trying to make the patient as comfortable as he is, and try to achieve the I go by 3 rules. Just the patient to have to being comfortable, having good quality BA, and quantity. Because remember, these patients mainly comes from uh, low visual acuity, and just gaining that little can mean a lot. I just recently fitted corneal dystrophy, and this patient was actually hand movement, and it went, and kind of like I wish it was more, but it went almost to 2400 or so. But he was happy. He was happy because he was comfortable. He gained quantity and the quality, because he told me, or just right away, I can see a more defined image. So yeah, as a practitioner, we always try to achieve what's best, but you have to comply with whatever you get, and if the patient is happy, just go with it. But yeah, our approach is always try to give the best quality vision to our patient, even if that means being a little bit. So again, one set for prolate or oblate cornea, it doesn't matter. 2 diameters, and one set for ocular surface disease. And by meaning ocular surface disease, we know with ocular surface disease, the most common thing to do or go is try to cover as many of the eye surface. So a large diameter will work better. But if we have like a dry eye, we can still manage with a 14.8. Just make that like a spa for that cornea, and make it like filling it out with some lubricating drops as well. Yesterday I was in a meeting that they suggested just putting a drop of gel, like doing it more viscous. And yeah, that's a good thing to do. I usually go to with hyaluronic acid of 0.4 concentration, and that works as well. So again, you can do a severe a severe dry eye with a 14.8, but if we have like a Steven Johnson's or Sjogren, like a more kind of like uh, precise uh, problem, then we will just want to go and cover as much area as we can. So 16.3 diameter can work really well with those, or just go above to a 17 diameter. So again, one set for small and large eyes, like we discussed earlier. Again, remember that we have those tight eyelids or small apertures on the eye. So basically fitting 16.3 on those eyes is quite challenging. We can do so, but it's gonna be basically technique. Um, I fitted one patient that has that like really small eye aperture, and it was tough. It was I remember if it was a 16, but we can do it, and he actually managed to do it by his own means. So we can do it, but we have the ability with this lens, and sometimes I wish I had that one for that patient in particular, and just go with a small scleral lens, like a mini scleral lens, right? So again, this is for symmetric or asymmetric scleras. Um, just again, reassess what you're seeing on the slit lamp, and according to what you're seeing, you can just adjust it. And as mentioned before, you can go the asymmetric lens. You can go to a symmetric lens if you don't see a need for it, or the symmetric lens, you can go to an asymmetric type of lens just by doing toricity on those lenses. So, but yeah, the standard is you have the 14.8 as a symmetric with the LLC stip value as 0, and the asymmetric with the 16.3 with toricity of 125 microns. And sometimes with a cornea or sclera, sorry, and a lens landing on a 16.3, sometimes 125 microns may be short. Then you would just want to go maybe so 50 microns. It's just gonna depend actually, but CAT group or the CAT design group with Randy made studies with the Pacific University, and they came across that 125 microns most of the times work with those type of scleras. So yeah, you can just like mentioned before, and if I'm doing a 17, probably so that I would just go a little bit higher on toricity and just make a 200 microns. But that's me, and every practitioner has their own mindset, and it's up to you by assessing doing a good assessment on the slit lamp. So again, this is the ICD FlexFit. Like I was telling you, it was a brief introduction, and it's a 14.8, 16.3 diameters on the diagnostic set. But you can just go larger or smaller on each diameter. Again, you can go to a 14 with a 14.8 up to a 15.5. With the 16.3, you can go as low as a 15.5 and go as high as a 17 millimeter diameter. So you have a symmetric and dual depth lens, basically an asymmetric for any type of asymmetric corneas, and multifocality and displays optics on the multifocal zone. So this is ICD Flex. I want to ask you if you have any questions, please, can you say it?
Okay, guys. So today the introduction for ICD Flex was given to you. I know that you might not have a lot of experience fitting scleral lenses, but we're going to do multiple events like this to teach you how to fit scleral lenses properly. Also, Dr. Nesar Damati from Jordan will be joining you for an entire week to train you on scleral lens fits. I'm also going to go to Saudi with Mr. Ibrahim and Mr. Tamer in order to give you more education and more training for ICD Flex. We have a question from
Mm-hmm.
Dr. Tamer. How does ICD Flex lens compare with hybrid lenses in terms of vision, correction, and comfort? Tamer, this is a great question. Scleral lenses are more comfortable than hybrid lenses.
Yeah.
Scleral lenses also provide better vision acuity than any hybrid lens in the market. If you were to take a patient and you put him in a hybrid lens versus a scleral lens, such as ICD Flex, you're going to have a report from the patient that states that the scleral lenses give him better vision and better comfort than the hybrid lenses. Please remember that scleral lenses position themselves in the white portion of the eye, and they don't have much movement. Also, there's no lid interaction. So when the patient blinks, they're not going to feel the edge of the lens. Also, please remember that hybrid lenses do touch the cornea, whereas scleral lenses do not touch the cornea, and we have more nerves in the cornea than the actual sclera.
Yeah, that's a great answer, Felipe. And yeah, I will agree on every single point that you gave. And just remember that hybrid lenses have that soft skirt. And if you have dry eye, that soft skirt is gonna be an issue. So yeah, that makes it uncomfortable for the patient. If like in Saudi, you have a lot of warm weather, so yeah, you probably so it's gonna be kind of rough. You have to like really examine that dry eye for a patient before going to an hybrid lens. Just as another side note.
Correct. So they ask us about future sessions. So after this meeting today, we're going to send you the recording, of course, but we're also going to send you a lot of webinars and a lot of classes that you can watch and learn in your own pace. So I'm going to email Tamer and Mr. Ibrahim today a lot of sessions, pre-recorded sessions that every single one of you should watch at your own pace, at your own time. How does ICD Flex perform in patients with severe dry eye, like Sjögren's syndrome, chronic ocular inflammation, and computer vision? Tamer, scleral lenses are the number one option for Sjögren, Steve Johnson syndrome, host syndrome, and a lot of ocular surface diseases. It is the number one treatment in the United States for ocular surface problems such as the ones that you're describing. In fact, we are doing a workshop in Hong Kong next week on dry eye and scleral lenses. Scleral lenses are the number one option right now for people with dry eyes and people with Steve Johnson, Sjögren syndrome, host syndrome, and a lot of the ocular surface disease problems that you can encounter in the ophthalmology area in Saudi Arabia. Yes, my email is as follows. And I will always be here to answer all your questions. You can also email us whenever you have fitting consultation questions, you're fitting patients, or you have questions about performance or anything in regards to the lens. We're always going to be here for you through those two emails.
Yeah, so Felipe, you I don't know, but I think you posted it for host and panelist.
Oh, I'm so sorry. Give me 1 second.
Hmm.
Let me copy this two emails. Our two emails are this ones. The first one is myself, and the second one is for consultations, fitting, any questions that you have in regards to the actual lens, what you should do about the lens, or when you have questions from your doctors, your customers, you can always email us using those two email addresses.
Yeah. So I don't know. Is there any other question?
Are there any other questions, guys?
Believe.
Yeah, so I don't see any other questions. So it is very important to understand that you have one of the best designs in the world in your hands right now. You are going to have multiple customers interested in this design. It is manufactured in the United States. It has the highest technology available to you. So please use it. Let us know if you have any questions. I hope that Mr. Ibrahim and Al Jamil Optical make a lot of business with this lens in Saudi Arabia. But in order to do that, we need to train you to the fullest. So please contact to us with questions. Let us know if you want to do additional sessions. But it's very important that today you receive an email with all the different sections in regards to scleral lens fitting and how to start a contact lens practice using scleral lenses. So I will
And
see you at the end of April. I will see you at the end of April. Please let me know if you have any questions in the meantime. And Mr. Tamer, please make sure that your entire team watches the webinars that we're going to be sending them, okay?
as well with this one, right? We will be sending
As
this
well
one.
with this one, correct.
Yeah.
Okay, guys, I'm looking forward to seeing you again. Thank you so much. Take care. Bye-bye.
Bye-bye.